diaspora and the motherland to enhance and empower the social capital of the community, inculcating the core values of diversity, cooperation, and excellence. The mission of this organization is to work closely with the people of Kerala origin across the globe to effectively promoting our integration and solidarity, exchange and cooperation, empowerment and recognition through programs, projects, and the institutions of innovative nature in the area of human, economic, cultural, social enhancement, and empowerment to augment and channelize the social capital of the Malayali community for a productive and sustainable future. Our objective is to provide a global platform to bring together the widely scattered Malayali community around the world to propagate our language, Malayalam, practice our culture, and to inculcate the rich traditional values among us and in our next generation. WMC is also a meeting point for interested Malayalis from all over the world to open up new possibilities for their economic and social growth. WMC always at the forefront to recognize Malayali talents, intellectuals, and entrepreneurs across the globe and leverage their skills to mobilize youths and women for their socio-cultural and professional enrichments. WMC works towards an international brotherhood of Malayalis, people of Kerala origin, to bolster their cultural, artistic, and social uniqueness and give resilience and understanding towards other cultures and which they have to coexist and interact. We closely work with the government of Kerala and actively participate and contribute to many programs for the betterment of Malayalis. WMC contributes 25 lakh rupees as a scholarship for school students, built 3 rooms for one of the cancer treating hospitals in Kerala, distributed 20 TV units to the Punalur Government Hospital are only a few recent activities among them. WMC has constituted worldwide regional and provincial councils with the eminent Malayali distinguished leaders from nationally and globally. Dr. P. A. Ibrahim Haji, Mr. Gopalapilla, Mr. John Mathai, Dr. Vijay Lakshmi, Mr. P.C. Matthew, Mr. Philip Thomas, Mr. Sudhir Nambiar are a few current leaders. I don't want to take too much of your time, so let me invite Mrs. Alice Manjeri to say the welcome speech. Thank you. Alice Manjeri, can you hear us?
Unmute ചെയ്യണം.
കേൾക്കുന്നുണ്ടോ?
ഇപ്പൊ കേൾക്കാം.
ഓക്കെ. ഗുഡ് ഈവനിങ്. ഏവർക്കും എൻ്റെ വിനീതമായ നമസ്കാരം. എൻ്റെ പേര് ആലിസ് മാഞ്ചേരി. അമേരിക്കൻ റീജിയൻ വിമൻസ് ഫോറം സെക്രട്ടറി എന്ന നിലയിൽ ബ്രസ്റ്റ് ക്യാൻസർ അവയർനെസ് എന്ന പേരിൽ ഈ ഇവന്റ് നടത്തുന്ന ഈ അവസരത്തിൽ നിർഭാഗ്യവശാൽ നമുക്ക് എല്ലാവർക്കും നേരിട്ട് കൂടാൻ പറ്റാത്ത ഇപ്പോഴത്തെ ഈ സാഹചര്യത്തിൽ ഫേസ്ബുക്കിലൂടെയും വാട്സാപ്പിലൂടെയും സൂമിലൂടെയും ഇതര മീഡിയകളുടെയും ഈ പരിപാടിയിൽ പങ്കെടുക്കുന്ന എല്ലാവർക്കും എൻ്റെ ഹാർദവമായ സ്വാഗതം. Now I cordially welcome our respected speakers. We have an excellent panel here with all the expertise. I wish you, it is a blessing that you all are here and willing to do the seminar virtually. Now let me welcome Dr. M.V. Pillai, MD, Dr. Sarah Isho, MD, Dr. Elizabeth Maman Prasad, MD, our moderator, Dr. Indu Savanani, MD, Dr. Julie Cabralio, MD. I wish you all the best. We are eagerly waiting for a fruit-filled seminar. Now I would like to welcome our American Region Chairman, Mr. Philip Thomas. My hearty welcome to our Global President, Mr. Gopalapillai. He is with this organization from its childhood. He knows all the ups and downs and all the happenings World Malayali Council, global and regional level. I am also to happy welcome Mr. P.C. Matthew, Global Organization, VP. I know he will not rest until all the regions of American and global have a World Malayali Council formed, also Women's Forum formed. I most welcome Mr. P.C. Matthew. I like to welcome also Mr. Chako Koikalat, Advisor Chairperson. We are always like to have your advisors in American region and all the provinces. I like to welcome American Region Vice President Aldo Peter and Administrative VP, Mr. Johnson Talachallur. We are so blessed to have two young, energetic leaders in American region as our president and secretary. With their humble, friendly deeds, make us easy to approach them anytime, and they are ready to help us regardless how busy they are. I extend my welcome to Mr. Sudhir Nambiar, our president, and Mr. Pinto Kannambulli, general secretary. I also welcome Vice Chair Mrs. Shanda Pillai, and Mr. Philip Marriott, and the Treasurer Cecil Cherian. I will welcome the Women's Forum President Shoshama Andrews, American Region, and the Treasurer Betsy Lee Abbey. And my cordial welcome to all the Women's Forum members in all the provinces and all the provinces. I extend my welcome to all the province chairpersons, presidents, and all the EC members, and also all the association leaders, including FOCANA, FOMA, and other Malayali associations around USA. Finally, I welcome each and everyone to this program. Sorry if I miss anybody's name. So now I invite Mrs. Shoshama Andrews, American Region Women's Forum President, to say a few words about Women's Forum.
ചേച്ചി അതിനു മുമ്പ് ഒരു സെക്കൻഡ് നമ്മുടെ ഫൗണ്ടിംഗ് മെമ്പറായ ഡോക്ടർ ജേക്കബ് സാർ ഇവിടെയുണ്ട്. സാറിനെ ഒന്ന് വെൽക്കം ചെയ്ത് ചെയ്യുന്നതായിരിക്കും നല്ലത്.
Okay. Also, I welcome Dr. Jacob. I didn't know him personally, but I hearty welcome to the program. Most welcome, Jacob sir. Shoshama Andrews, I invite for the program to say about few words about the Women's Forum.
മ്യൂട്ടിലാണ്, അൺമ്യൂട്ട് ചെയ്യും.
Thank you. Kekamo.
Yes.
Thank you, Alice. Greetings to all. I am Shoshama Andrews, American Women's Forum Chair President. October is the month for breast cancer awareness month. So think pink. So we the team under the leadership of our American President, Region President Sudhir Nambiar, our General Secretary Pinto Kannambulli, and our Treasurer Cecil Cherian, and all the global team. And we all decided to do our seminar this month. I am officially congratulating our Women's Forum team for their accomplishment. Our mission is to empower the ladies and promote their talents to our community and encourage them to actively participate in social activities. Now our mission is to actively participate and collaborate with the other provinces, with the members and other women members in our province. Our goals to establish more women's forum in each state and bring them in another level. Our future plan is to empower all the women and also nurture everyone to reach their fullest potential. Our group mentoring and opportunity to network for the plan for the future. Overall growth of team members is our plan to promote culture, and charity event is our plan for the future. Now I am inviting our chair, vice chair, Mrs. Shanda Pillai, for the American region to introduce our moderator, Dr. Elizabeth Maman Prasad. Please welcome her for this event. Thank you. Welcome to you all.
Thank you, Ms. Susanna Andrews. Respected guests, WMC leaders, Women's Forum officials, and my friends. My responsibility today is to introduce the moderator for Breast Cancer Awareness Program organized by World Malayali Council, America Region Women's Forum. I am very honored and privileged to introduce our moderator for today's program, Dr. Elizabeth Maman Prasad. Dr. Elizabeth Maman Prasad is an infectious disease physician affiliated with the several New Jersey hospitals for past 30 years. Dr. Elizabeth Maman Prasad is currently the president of medical staff at East Orange General Hospital and previously chief of ID division. She is very active with various community projects and she enjoys travel, gardening, and please let us welcome Dr. Elizabeth. Thank you all.
Yes. Thank you for that kind introduction. Can you hear me?
Yes.
Yes. Good evening to all of you, and thank you for all the online audiences. It gives me great pleasure to moderate tonight's program on breast cancer and the World Malayali Council America region for hosting this virtual program to bring breast cancer awareness to the Indian American diaspora community and to the community at large. It gives me great honor to introduce the speakers for the night who will share their knowledge for breast cancer from risk factors, signs and symptoms, diagnostics, and treatment, and finally on what to expect from breast cancer treatment centers. Before I introduce the speakers, let me give a short overview of tonight's program. Our program consists of two segments. In the first segment, the speakers will talk about their assigned topics for about 10 to 15 minutes. After all the presentations are completed, we will transition into the segment 2, which will be a Q&A session. That will be an interactive session, so please send your questions in via chat into the question box so you can ask the questions directly during the Q&A session to the panelists. Please check the Facebook Live link in the chat and send the link to your family and friends so they too can join in this virtual session. I would like to start off tonight's program with a quote from a Dutch philosopher from 1500 by the name of Erasmus, who stated, quote, "Prevention is better than cure." This quote is spot on for our topic today on the title Breast Cancer Awareness. World Health Organization established October of every year as Breast Cancer Awareness Month across the globe, an effort to remove the stigma of breast cancer through education on early detection and increase the chances of survival. There are 1.7 million breast cancer cases every year and over 500,000 deaths each year globally. In the US, every 2 minutes, a woman is diagnosed with breast cancer, and in India, every 4 minutes, a woman is diagnosed with breast cancer. Breast cancer affects both women and men. Although breast cancer is rare in men, it does occur about 1 out of every 100 breast cancer cases diagnosed in the US. Breast cancer in men tends to be diagnosed much later in life and tends to be advanced when diagnosed and has a higher mortality. So the breast cancer awareness program is not just for women, but for men as well. So now let's hear from our panelists on breast cancer. Our first speaker is a well-known speaker globally, Dr. M.B. Pillai is a hematology oncologist with more than 30 years of experience in the United States and currently serving as a clinical professor of oncology at Thomas Jefferson University in Philadelphia. Dr. Pillai is currently the president of International Network for Cancer Treatment and Research. His hobbies are travel and poetry. It gives me great honor to introduce Dr. M.B. Pillai, who will speak on risk factors and touch upon signs and symptoms of breast cancer. Please welcome Dr. Pillai. Pillai?
Can you see me? Can you hear me?
Now we can hear you and see you.
Okay, very good. Thank you for the very kind introduction. And it's 7:31 now. I have 15 minutes to talk about the topic assigned to me. And I thank the World Malayali Council, the Women's Forum, and particularly the veteran leaders of the World Malayali Council. I don't want to name all of them because it's going to take away the time allotted for my subject matter, and the Women's Forum, and my colleagues who are covering the topic. Breast Cancer Month of October every year is actually a very important turning point in the life of women all over the world. The world statistics of incidence and mortality have been very aptly presented today, and I don't have anything more to add. But I just want to highlight the point. By December 31st, we would have lost about 280,000, actually incidence-wise, 280,000 new cases of breast cancer in USA by the 31st of this year, 280,000. And about 40,000 women would have died with breast cancer in USA. I want to take you to India, where the annual incidence of breast cancer is about 155,000, and about 76,000 will die of the disease. So you can see that the mortality there is very high. What has been the phenomenal change in the landscape of breast cancer in USA over the past 10, 12 years? The incidence rate is slowly but steadily coming down, the incidence rate. And so is the mortality rate. And this is probably what transpired the enthusiasm all over the world, that if the United States can do that, why not we? So over the last few years, the National Cancer Institute is publishing that the actual true incidence, age-adjusted incidence of breast cancer is slowly coming down in USA. And the reasons are very manifold, and I can touch upon that very shortly. But more importantly, the death rate from breast cancer is also coming down. Keep in mind that the death rate due to cancer in USA, right now, number one is lung cancer, even for women. Not only because the lung cancer is going up in incidence, but the mortality from breast cancer is coming down. So the second most common cause of death for women from cancer in USA is breast cancer. When you come to India, the Lancet published an article about 3 months ago that of the 29 states and 9 union territories in India, Kerala leads in the incidence of breast cancer. Not only that, Kerala leads second in mortality from breast cancer. The first rank goes to Mizoram. So all Malayalis around the world should be aware of the fact that when the United States is winning the fight against breast cancer by bringing down the incidence and the mortality, our home state is going the other way. Our incidence rate is going up and our mortality is going up. The last piece of statistics I got from the Regional Cancer Center, Trivandrum, last week, says we had about 6,789 new cases diagnosed this year. And keep it in mind, this may be a gross understatement. Not all cases are registered in Kerala due to a variety of reasons, like the stigma attached to it. Many patients go to centers other than Regional Cancer Center. So this may be an underrepresentation. Still, some data is good. But the most startling finding is of 6,789, more than 70% of them are presenting with advanced disease, stage 3 and stage 4 disease, which are not curable. So no wonder that with an 155,000, we have a mortality of 76,000 in Kerala now. This is based on the available meager statistics from One Cancer Institute. So you can imagine what's going on all over the state. What's going on in the epidemiology of breast cancer? And here is a list of things which I want you to take home with. The most important thing is the median age in USA. Median means half the people are above this age, half the people are below this age. In United States is 63. 63, 2 years before you are eligible for Social Security. Go back home in Kerala, the median age is 45. So right now, younger women in Kerala are afflicted with breast cancer, whereas in the United States, the median age is 63. What about the incidence in USA? The incidence both in the white women and the African American women. But here again, the mortality for African American women is much more than the mortality in the white population, mainly because of late diagnosis and socioeconomic reasons in interfering with optimal treatment. So when you take up the risk factors, the first and foremost is old age. An aging population of women makes them susceptible to breast cancer. To understand this phenomenon, when India became independent in 1947, our lifespan was 31 years. People used to live up to 31. Today, in 2020, Kerala women have an average lifespan of 78 years. So just imagine, from 31, we have come up to 78. There is an aging population of women in India in general and in Kerala particular. And aging is a very big risk factor. Why is it that when women age, they have a higher risk of breast cancer? Excellent hypothesis. If you have menstrual cycles for years and years and years, that set the ground for breast cancer. And during these menstrual cycles, your estrogen level remains very high. Now, estrogen alone is not causing cancer. But if something else causing cancer in your body, estrogen can stimulate it or make it happen faster. We still don't know why not all the women get breast cancer. So there is an environmental factor, what we call as an epigenetic factor, which is triggering the cancer. But estrogen is the number one villain, which can prepone it, make it worse, or make it faster. So estrogen is the number one villain in the genesis of breast cancer. So if a girl attains menarche at the age of 11 and the lady has a menopause at the age of 50, you can imagine for 39 years, the amount of estrogen that has been poured into her system, which is a high risk factor. And this is why early menarche, attaining menarche or starting the periods at 11 or 10, very common in Kerala right now, will put you at a higher risk. Studies have shown that for every 1 year delay in attaining menarche up to the age of 15, there is a reduction of 3% in the risk for breast cancer. Same thing happens with menopause. If women take longer time to attain menopause, then there is a prolonged period of exposure to estrogen. Starting from early menarche to late menopause, there's a field day for estrogen in the woman's body. How is this punctuated? In olden days, an early pregnancy, say right around the age of 20, used to reduce your risk for breast cancer by 30%. A pregnancy right around the age of 20, full-term normal pregnancy, will bring down your risk by 30%. Every other pregnancy from the age of 20 to 30 will bring it down by another 7%. No wonder our great-grandmothers who used to have 10, 12 children never had a problem with breast cancer. Because they get married at the age of 17 or 18, they have the first baby by 19 or 20, they keep on delivering till about 30, 35, and every birth used to give them a 7% protection against breast cancer. This is what has changed due to socioeconomic reasons. We attain menarche early, and then marriages are delayed. The first full-term childbirth is delayed, and many people are even avoiding childbirth. And the menopause is delayed due to a variety of reasons.
World Malayali Council.
Hello? Okay. So this exposure to estrogen, starting early in life, at the age of 11 or 12, going all the way up to late menopause is a major risk factor for breast cancer. That's why when you get old, you had been exposed to a sustained elevated level of estrogen for a long period of time. Before independence, most women used to live up to 31, 40, 41. So they never lived long enough to have the risk of a breast cancer. The second most risk factor which you need to be aware of is previous breast disease. A lot of women have so-called fibrocystic disease of the breast. And again, I want to add that not all fibrocystic disease of the breast are precancerous, but some of them have what they call as with atypical cells. When you do a fine needle aspiration, the pathologist will say that the fibrocystic disease has cellular atypia, ATYPAA, and that's a warning sign. So DCIS, or ductal cancer in situ, which is a 20 to 30% risk for breast cancer. Lobular cancer in situ. In situ means it hasn't gone anywhere. It is sitting there. It's a relatively harmless lesion. Those are early breast lesions which you need to be concerned about. And that puts you into a high risk factor for breast cancer. The third one is inherited risk. We all know that cancers start in the genes. Sometimes the genes responsible for preventing cancer can be mutated. If the cancer prevention gene is mutated or weak, there is nothing to suppress the production of cancer. Every day we are exposed to so many carcinogens, and our cells are dividing fast, particularly in the breast, where the proliferative index is very high. And when these cells are dividing day by day, all it takes is one cell to go out of whack. And that faulty cell can sit there and turn into a cancer if there is a carcinogen acting in the body. That's why we are very concerned about the environmental factor and the genetic factors. When the genes are out of whack, then you have a risk of breast cancer because the capacity to suppress these cancer cells from multiplying is lost. And there are two cancer-producing genes which you should be aware of. They are known as BRCA, breast cancer 1 and breast 2. And for short form, doctors use the term BRCA1, BRCA2. So when you go to see a doctor, the doctor says, have you been screened for BRCA1, BRCA2? This is what they are alluding to. Breast cancer 1 and breast cancer 2. In US population, except in Ashkenazi Jews, where the incidence is 30%, if you take the whole US population, the incidence is between 5 to 10%. And here is the red flag. In Kerala, the incidence is now between 20 to 25%. So we have a population of women who have a BRCA1 or BRCA2 positivity. And this BRCA1, BRCA2 positivity are tumor suppressor genes, genes which can prevent the cancer from unfolding. If they are weak, the body loses its capacity to prevent the cancer. So there is a high incidence. If you ask any of the oncologists in Kerala, they will say, I have about 20% of my patients are BRCA1 mutated. BRCA2 is equally important because it can run in families. Both of them can run in families. It's autosomal dominant. And interestingly, the BRCA2 is associated with male breast. There is a question whether men can develop breast cancer. Yes, they can. The actual incidence is 1 out of 1,000 cancers. And if you want to take it out of breast cancer, 1 out of 100 breast cancers hits the men. Relatively less common because the men's breast does not have enough ductal tissue as in the women, but still they can have it. Especially if they have what we call as a gynecomastia, breast which mimic like a woman's breast. And there are conditions which can induce gynecomastia. In olden days, we used to treat prostate cancer with estrogen. And we now know that estrogen in excess can pave the way for breast cancer. So men who were treated for prostate cancer who develop gynecomastia have a higher incidence of breast cancer. There is also a disease called Klinefelter's. Some men are born with an extra X chromosome. We all know that XX means female, XY means male. Suppose you are born with XXY, that means you have acquired one more X chromosome. If you are born like that, then you develop a condition called Klinefelters, and those type of men have a high incidence of breast cancer. So if a man has BRCA2, BRCA2 mutation, or if a man has XXY chromosomal makeup or blueprint, or if a man has been treated with diethyl estrogen, then they have a high risk of breast cancer. This is where the family history is important. The fascinating thing about BRCA2, it's also associated with prostate cancer and pancreatic cancer. So if you get a family where lady has breast cancer and the brother has prostate cancer, father had pancreatic cancer, that's when the red flag goes up. This family has to be referred for genetic counseling to screen for BRCA2. All right, what else? Dense breast tissue is attracting a lot of importance. Women, particularly Kerala women between the age of 40 and 50, have dense breast tissue. When you say dense breast tissue, what it means, they have more fibroglandular tissue than the fat in the breast. So when you take an ordinary mammogram, the radiologist would say that the breast is too dense, so the mammogram may not be sensitive in picking up early lesions. So what do? Luckily, we have three-dimensional mammograms available now. And three-dimensional mammograms can pick up even slightest, smallest lesions, which may be missed in conventional mammograms, screening mammograms. So dense breasts have been identified as a risk factor for breast cancer. Next time when you go for mammogram, you can check with your doctor, do I have a dense breast or not? They can look at the breast mammogram and give you the answer. What else can cause breast cancer? We already touched upon the reproductive histology, early menarche, delayed first full-term childbirth, and late menopause. All will pave the ground for high estrogen levels, and that indirectly or directly causes a higher susceptibility for breast cancer. What else? Hormone replacement. Many of your primary care doctors in the past could have put you on hormone replacement to ward off the symptoms of early menopause. And that is how we detected that this is a risky thing. And interestingly, it is not the estrogen replacement that caused the problem. It is a combination of estrogen and progesterone. So hormone replacement has become less fashionable these days. Now, some of you may be worrying, how long is the risk lasting? If you took it only for 2 or 3 years, studies have shown that your risk is 0. Those women who took the hormone replacement for 3 years and beyond, they have the higher risk of breast cancer. What else? If you had radiation treatment to the chest, either for Hodgkin's disease or lymphoma in the past, then you have a high risk of breast cancer. The same thing is reported from nuclear accident sites like Chernobyl and atomic bomb survivors in Nagasaki. So the radiation is now recognized as a risk factor for breast cancer. Now comes the 20th century risk factor, obesity. Obesity, I repeat the word obesity. And if you want to find out whether you're obese or not, all you need is a Samsung phone or an iPhone. You can put your weight in kilogram and height, and the mobile phone will give you the body mass index. If your body mass index is more than 30, you are obese. If you are between 25 and 30, you're overweight. If you are less than 25, you're perfectly healthy. Newer studies are showing that if you are obese, your risk of post-menopausal breast cancer goes up by 40%. I repeat, post-menopausal. So what you're investing during your childhood, early adulthood, and adult, by keeping your body mass index in the normal range, is an investment for your middle age and old age. How does this happen? What happens when you are reaching the menopause? The ovaries stop producing estrogen. The body converts the estrogen precursors in your fat tissue to estrogen, using a hormone called aromatase, an enzyme called aromatase. This is why some women are taking aromatase inhibitors. You might have heard about the Femara, the Arimidex, the Aromacin. They're all inhibiting the aromatase enzyme, which converts estrogen precursors in your fat tissue to estrogen. Obesity is now well recognized as a risk factor for breast cancer. Last but not the least, alcohol, no matter how much you take, is now well recognized as a risk factor. Some of the factors previously suspected to be causing breast cancer are taken off the list. And you might keep that in mind too. Breast implant, and if you want such thing, tubal ligation does not cause any risk for increase in the risk. In vitro fertilization, there was some concern. Babies, when women have IVF, will they have a higher incidence? No. Studies have exonerated in vitro fertilization, electromagnetic radiation, mobile phones, high tension wires. There is an area of dispute about chemicals like whether DDT, fertilizers, diethyl dichloroethane, pesticides can increase your risk for breast cancer. The American, European, and Canadian studies have said no. But before we jump to these conclusions and make a frank statement that pesticides and chemicals are safe, I think we should have our own study, because the way we spray our paddy land in Kuttanad may not be the way they spray pesticides in Kansas or in Canadian farmland. So that's an open area for dispute. We still have to look into greater detail. Now, a word about the mammogram, maybe about 2 or 3 minutes. A lot of people have this question, who should have a mammogram? This is where a discussion with your primary care physician is an absolute must. We are entering into an era of shared decision making. I repeat the word shared decision making. The decision is shared between the patient and the doctor. How do you share? Because you can divide your patients into 2 groups, ordinary risk patients and high risk patients. Ordinary risk patients are people who have no history of breast cancer in the family, any hormonal replacement, who have no genetic predisposition ruled out BRCA1, BRCA2, no obesity, no use of alcohol, no past history of benign breast disease. So they're average risk. For them, when should we start the mammogram screening? Again, if you go back to Regional Cancer Center in Kerala, the peak incidence of breast cancer is between 45 and 60. The peak incidence in USA is 63. That is why in USA, there are 3 or 4 different groups arguing that why do you want to expose these young women to breast cancer? Their objections are threefold. One, there's a small amount of radiation to each man. That comes to about 0.4 millisievert. That's how much radiation you will get in 2 weeks by walking in the beach. But still, if you're going to have mammogram...
Dr. Pillai,
yes.
Thank you so much. We're running out of time, so we're going to go on to our next speaker. Thank you for giving us an elaborate risk factors. It's wonderful. In terms of other tests and so forth, we'll leave it to the other speakers who are being assigned that topic. But I really appreciate your vast knowledge on the risk factors. So we're going to move on to our next speaker. Thank you so much, Dr. Pillai.
You're welcome.
Stay on for the panelist portion for Q&A. The next speaker is, it gives me great privilege to introduce Dr. Sarah Esau, who is the Chief of Hematology Oncology and Director of Cancer Services at Monmouth Medical Center, Southern Campus in Lakewood, New Jersey. Dr. Esau is involved in community activities and served as chairperson of FOMA, Women's Forum, from 2016 to 2018. And under her leadership, was involved in charity projects that benefited programs in Kerala and in India. Dr. Esau is an avid writer and a literary editor and a columnist of a monthly magazine, Malayali magazine called Jane, as well as she has published a collection of essays in Malayalam. Please help me welcome Dr. Esau. who will talk about diagnostics.
Thank you very much, Elizabeth. It's always a very tough act to follow the eloquent speech of Dr. Amy Pillai. I am sure I'm not going to get anywhere near there, but please pardon me. I'm going to be sharing my screen with a few slides. So give me a second. So we are talking about breast cancer in October. We are all here in a rainy night because October is Breast Cancer Awareness Month. I want to commend World Malayali Council for making this program today to enrich our community regarding the importance of knowing about breast cancer, importance of screening for breast cancer and diagnosing it early. My goal today is to talk about how to diagnose breast cancer. We already heard from Dr. Amy Pillai regarding the incidence of breast cancer, and breast cancer is the most common cancer in women in the US, and second leading cause of cancer death in women, second only to lung cancer. So also it's the leading cause of death in women aged 40 to 59. So again, we heard the incidence, 1 out of 8 women will be diagnosed with breast cancer sometime during their lifetime. So that incidence is 1 out of 1,000 men. So we talked about the cancer incidence in men. Just to be aware of the fact that men can also get breast cancer, but the incidence is much higher in women, and it's much more common than we think it is. So before we go into the details about how to diagnose breast cancer, I wanted to show the normal anatomy of the female breast. So mainly the breast tissue is composed of fatty tissue. This is the yellow colored area is the fat in the breast. And then there are glands in the breast. These are the glands which have lobules, and from the glands arises the ducts, and the ducts lead it to the nipple. So the main component of the secretory component are the lobules with the glands, and there are the ducts. And then there are lymph nodes. From the breast tissue, the lymphatics or the fluids from the breast goes into the lymph nodes under the arms called axilla. And from the inner part of the breast, they go to the lymphatics inside the chest wall called the internal mammary area. So when we talk about breast cancer, most common type of cancer arises from the ducts of the breast. So we saw these are the ducts that come from the glands. So this is the normal shape of the duct, which is intact, but one of these cells can become cancerous, and the ductal carcinoma arises inside the duct. And when it is confined inside the duct and not going outside the membrane of the duct, it's called carcinoma in situ, or as DCIS. So ductal carcinoma in situ is called DCIS. And then when the cancer cells pierce the border of the duct and goes outside into the breast tissue, and it surrounds into the area of the breast, that's when the process called the invasion or invasive ductal carcinoma, which is which commonly known as breast cancer. But ductal carcinoma in situ is mainly called as a precancerous situation, or it can also be called a stage 0 breast cancer. So 70 to 80% of breast cancer is arising from the duct, but a minority of patients have lobular carcinoma, which happens inside the lobules. This is a normal lobule, and inside the normal lobules, when it becomes cancerous, it becomes in situ, and then when from the lobules, when it extends to the surrounding tissue, it's called invasive lobular carcinoma. So when you talk about breast cancer, when let's say somebody, your relative or one of you is diagnosed with breast cancer, there are a few things you need to know about your own cancer. Number one is the stage, and stage is dependent on a few factors. We also have to know the size of the tumor. We have to know if there are any lymph nodes involved with cancer. And in breast cancer cells, there are proteins on the surface of the cancer cells called, most important proteins or hormone receptors are called ER and PR, estrogen and progesterone receptors, and another protein called HER2 or HER2. So knowing about this receptor status is important. We will hear more about this when we talk about treatments. We also have to figure out what is the risk of relapse in somebody who is diagnosed with breast cancer, and what are the treatment options that are out there for that particular stage. So when we talk about staging, staging is based on the size of the tumor and whether there are any lymph nodes involved with cancer, and also whether there are any cancer cells out deposited elsewhere, a process called metastasis. So metastatic breast cancer can happen in different parts of the body, including the liver, lungs, and bone, and brain, and many other parts of the body. So when patients ask me, so how big is my tumor? And I tell them, oh, your tumor is 2 centimeters. And next question is also, how much is that? So to have a visual concept as to how much is a centimeter. So this is 1 centimeter tumor is close to like the size of a pea. 2 centimeter tumor is a size of approximately a size of a peanut. And then a 5 centimeter tumor is more or less a size of a small lemon. So this is just to have a visual idea as to how big the tumor is inside your body. So again, stage 1 is when the tumor is less than 2 centimeters and the tumor has not gone to any of the lymph glands. But if the tumor is more than 2 centimeters or it has gone to the lymph nodes, it becomes stage 2. Stage 3 is a larger tumor, which can either be more than 5 centimeters, or it can affect more lymph nodes, or it can be fixated to the skin or the chest wall. And stage 4 is when from the breast, it has gone to other organs, such as the liver, lungs, bones, and other areas. So why do we need to know the stage? Because stage and diagnosis matters. Because if you have someone who have a stage 0 breast cancer, that's a 100% cure if you get the right treatment. Even with stage, if you have a localized cancer, with the right treatment, you have a 98% chance of being alive at the end of 5 years. But if you were diagnosed when the cancer has already spread to other organs, your chances of living up to 5 years is now down to 30%. So it is important to know the stage, and it is important to be diagnosed at an early stage where you have a better chance of a cure. So one of the important things about breast cancer is that compared to other cancer of the other internal organs, such as pancreas or ovaries, because the breast tissue is outside and the symptoms and signs can present before it is too late. So if you watch out for the symptoms and signs of breast cancer, and in addition, there are imaging studies or X-ray studies which can diagnose breast cancer at a stage when there is not even any symptoms and signs. So you have a potential of diagnosing cancer at a very early stage, and that can lead to a cure. So that is why breast cancer mortality has declined in the last several years in the US, because more and more patients are diagnosed at an earlier stage. And in addition, there's also advances in the treatments for breast cancer. So the way of making diagnosis would be by looking at the symptoms and signs and looking at imaging studies. And once you have in either a lump or you have an abnormal imaging study, next step would be to do a biopsy. So what are the signs and symptoms of breast cancer? It can present as a lump. It can present as a palpable lump, which can be felt by routine physical examination by the person itself, called self-breast examination. The cancer cells can cause change in the size or shape of the normal breast. It can cause changes in the nipple with retraction or pulling the nipple in. There can be bloody discharge from the nipple in some circumstances. Sometimes there could be redness or skin changes, especially in a type of breast cancer called inflammatory breast cancer. The skin can become red and inflamed, and it would look like an infection in the skin, but there could be skin nodules or thickening, which needed to be biopsied to make sure that whether it's cancer or not. So the changes in the size of the breast and the shape and nipple retraction, these are things that a person can look for maybe every few weeks in the mirror and see if there is any changes in your body. And that would warn a person to get help or to have that examined to see if there is cancerous or not. So the screening for breast cancer. Screening means diagnosing a cancer at an early stage where it can be before even the symptoms arise. And once you diagnose an early stage, there is a better chance for cure. So examples of screening, one is screening for cervical cancer by doing pap smears. So similarly, mammograms are used to screen for breast cancer to be diagnosed at a very early stage. So diagnosing at an early stage leads to a better chance of cure. And studies have shown that in women older than 50 years, doing a screening has resulted in a 22% reduction in mortality by regular screening. Of course, there are downsides to screening because sometimes mammograms can cause false positive tests, and that may lead to unnecessary biopsy and feeling of anxiety for the person and for the family. So to know more about the mammograms, like Dr. Pillai said, mammogram is actually an X-ray examination of the breast. And even about a century ago, X-rays were used to examine the breast tissue by a German surgeon called Albert Salomon. And the modern mammographic machine came into existence in the late 60s. So since then, technology has advanced significantly, and now we have modern machines that are safer and use the lowest possible dose of radiation. Dr. Pillai mentioned that the average dose of radiation is 0.4 millisieverts from the mammogram, and we are normally exposed to more close to 3 millisieverts of radiation from our environment. So the harm from radiation or the risks from radiation from mammogram is lower than the benefits from mammogram. And then there is digital mammography, where the films are digitalized and it's more advanced machine. And the latest technique is something called 3D mammogram or tomosynthesis, where you are able to create 3D images from doing one or two studies. So that will give a clear picture, especially in somebody who has dense breasts. So a picture is worth 1,000 words. This is an abnormal mammogram in a person. When you do a mammogram, you're mainly looking for three things, mainly calcifications. So calcifications can be macro calcifications, which are bigger specks of calcium, which is related to aging, and calcium deposits are seen in the blood vessels or old trauma, and that are not something that needs to be concerned about. But when there are microcalcifications, I don't know if you can see this screen clearly, there are tiny, tiny specks of white spots here. So that tiny calcifications can be associated with cancer. And then there is, in this particular film, there is a small dense area here, which is separate from the rest of the breast. So that's a mass-like density. So masses can be solid or cystic, and some of the solid masses could be benign, and cystic masses are contained with fluid. But when it is cancerous, usually they're solid, but they have spiculated or irregular margins. And those suspicious masses are the ones that needed to be further investigated. Then Dr. Pillai talked about the density of the breast. So mammograms assess the density. It does not necessarily mean cancer, but the risk is higher for breast cancer in women who have dense breast. And the other fact is that when you have a dense breast, you are not able to diagnose cancer as clearly. So this is the picture of several different density levels in the breast. So if you look at this particular image, you can see that it's much more clear, it's much more darker, and there is no irregularity. So this breast is entirely fatty. But in this area here, the whitish in the middle, those are the fibroglandular density. So there is scattered areas of fibroglandular density is seen in this image, but when you go here, this is a heterogeneously dense breast. So there is very little fatty area here. It's all thickened and opaque, and this is an extremely dense breast. So what is the problem with having dense breast? In addition to the fact that people with dense breast have a higher chance of getting breast cancer, it will be very difficult to diagnose small tumors in the dense breast by a mammogram. So this is a fatty breast, and this is a tumor. We can see it very clearly. However, in the dense breast, even if there is a mass underneath here, it won't be easy to detect that. So we talked about screening. When should one be screening for breast cancer? Again, it's a controversial subject with different organizations. Most people agree that there should be some kind of discussion when a woman is 40 years old. You should have a shared decision making between the physician and the patient in an average risk person regarding doing mammograms. In the American Cancer Society recommends doing annual mammograms starting at the age of 45. I can start at 40 if the physician and the patient agrees that that they should get a mammogram, and then afterwards, after 55, the choice is either an annual mammogram or a mammogram every 2 years. So this is the screening recommendation for an average risk woman. So average risk means someone who has a less than 15% lifetime risk of getting breast cancer. So again, between the ages of 25 to 40, there should be awareness about breast tissue, awareness about the changes that can occur in the breast, and if there is any kind of changes or suspicion, a clinical encounter is recommended. But more after age 40, again, an annual physical examination and a screening mammogram. But in somebody who has an increased risk, and the risk is, we heard about risk, so the risk will be somebody who has a lifetime risk of getting breast cancer more than 20%. So with the radiation, family history, and genetic predisposition, all that increases the risk of getting breast cancer. So those who are high risk has to start getting mammograms at a much earlier age. So usually the recommendation is to start screening the higher risk women at least 10 years prior to when the youngest family member was diagnosed with breast cancer, but not prior to age 30 or at age 40, whichever comes first. For example, let us say somebody has a sister who was diagnosed with breast cancer at 45. The siblings should be screening at least by the age of 35. So 10 years prior to when the youngest family member was diagnosed with breast cancer, but not before age 30, but it has to be at least by age 40. That will be the screening recommendation for women who are at high risk of getting breast cancer. Then, in this high risk women, we would recommend doing the 3D mammograms or the tomosynthesis. And also, because they may also have dense breast, we would recommend doing a breast MRI, again at the same kind of timeline. And if somebody cannot get an MRI for any reason, they could do a breast ultrasound or a special kind of mammogram called contrast enhanced mammography. So once you find a mass either by looking at your breast or by examination or by a screening abnormality, the next step would be to get a diagnostic mammogram. So routine mammograms are done as 2 views, and that is just to screen and see if there's any abnormality. But once you find any abnormalities in the screening mammogram, you have to almost always do a diagnostic mammography, which includes taking multiple views to further localize this particular abnormality in the X-ray. And they would also need, most likely need an ultrasound to further characterize this lump or this abnormality in the mammogram. And then once you find or delineate this mass, you need a biopsy to find out whether this is cancerous or benign. And the biopsies are done either by ultrasound guided biopsy or something we call as stereotactic biopsy if it is only identified by the mammogram alone. So there are main biopsies are either using a fine needle or fine needle aspiration, but it's only able to get a very small sample of cells. The preferred approach is called a core needle biopsy, which is usually guided by an ultrasound or an MRI. You localize the mass with either with the ultrasound or the MRI and put a core needle, a bigger bore needle into the tissue. And in some cases, you'll have to do an open biopsy by surgical techniques. So that's how you diagnose breast cancer. And then once you have the diagnosis, we have to know certain features, like we said before. After a person is diagnosed and have their initial treatment, we need to discuss about what are the features that determine what is the risk of relapse. So again, it's depending on many factors, including the grade of the tumor, the receptor status, the tumor size, and also there are some genetic factors or some gene profiling that you can do that will determine the risk of relapse in a certain, in certain individuals. So there's in the new tools in the genome here, there's a testing called Oncotype DX. I think Dr. Indu will be talking about that with the discussion of treatment. So my one point I want to emphasize is that no two tumors are alike. Just because your friend or your cousin was diagnosed with stage 2 breast cancer, that does not necessarily mean that your cancer at age 42 or 45 will be the same. These are 2 of my patients. One was diagnosed at age 45 with stage 2 breast cancer. And she was treated with the lumpectomy, radiation, chemo, and hormonal treatment, but she developed metastasis in 3 years and she died. But there was another patient with the same stage, same age of diagnosis, and same kind of treatment, but she is still alive and well 8 years later. So there is so much that we don't know about in each individual. Each person is different, each cancer is different. So we have to currently identify the genomic profile of each person, and the future is going in that direction towards personalized treatment. So I'm going to stop here. Why do we need early diagnosis? Because early diagnosis is where you can diagnose cancer at this stage with a very small speck of calcium in the mammogram. But if you don't do that, it can lead to this very unsightly and horribly painful and mutilating mass in the breast, or it can become stage 4 breast cancer with cancer spreading to other organs and people, and it's not curable. So early diagnosis saves lives. So knowing about breast cancer is not enough. We need to take care of yourself and don't delay your mammogram. And thank you very much. And I will be happy to answer any questions later. Thank you.
Thank you, Dr. Esau. Wonderful presentation, very insightful. At this time, I would like to move on to our next speaker. It gives me great pleasure to introduce a dear friend and colleague, Dr. Indu Sabnani, who is a hematologist oncologist in private practice in Maplewood, New Jersey, and is affiliated with Newark Beth Israel Medical Center for over 30 years. Dr. Sabnani is one of the most compassionate oncologists I've ever met. And her patients rate her as the most caring physician, has the best bedside manner when one is faced with challenging diagnosis of breast cancer. And she walks with you through this process. It gives me great honor on a personal level to introduce Dr. Indu Sabnani, who will talk about the treatment of breast cancer. Please help me welcome Dr. Indu Sabnani.
Hello, Elizabeth.
Yes, you're on, Indu.
Okay, hi. Thank you so much for such a wonderful introduction. And it has been such an enlightening evening for me, after Dr. Pillai and Dr. Essa, and to see that how much the community, how much your society is doing for the community, which is so wonderful. And I learned a lot from Dr. Pillai about the incidence of breast cancer in India. And, not even a week goes by where I don't get like a second opinion or consultation or from a distant relative that someone has a cancer. So it's not only the breast cancer. I think in India, there is as such how the cancer diagnosis is becoming very common, and cancer is being seen even at a younger age. So, I have been in, and it's really a privilege here, and thanks for the invitation and giving me the opportunity to discuss today the treatment of breast cancer. And I'm going to share some slides. And breast cancer is a very complex disease. So give me 1 second to share the screen. Okay, so breast cancer is a very, very complex disease. As Dr. Essa said, that there are no two cancer patients are alike. So my goal here is to simplify this complex problem. So when the patients, they come into my office.
We cannot see your slides.
Your slides, Indu.
You cannot see the slides? Okay, give me 1 second.
I think your camera is off, Indu. Turn on the video.
Yeah, Indu, we can't see you either.
Yeah, hold on 1 second. Okay, here we go. How about now?
Yes, the slides we cannot see, but we can see you.
Share screen. Okay, I
There we
think
go.
maybe there we go, right? Okay, how about the now? Sorry for the delay.
That's okay. We can see the slides now, Indu.
Okay, perfect. So as I was saying that the treatment of breast cancer is very complex, and that my whole goal for this one is to simplify the treatment as much as possible for all of us, because there's a lot of audience where they may not get too many medical terms. So we will try to keep it very simple. So when patients, they walk into my office and with the diagnosis of breast cancer, they are very anxious. They are really overwhelmed. They go on Google, internet, and they get so much information and they get more scared. So I tell them that the first step is that you can conquer the cancer with confidence, that you have to confront it with confidence, that there is no role of fear. Always be faithful, have faith. And why we say faith? Because there is so much has happened. Faith in science, whether it's the faith for coronavirus or faith for breast cancer or for lung cancer, that we have to have some faith in science, because that's the only way that we have come so far. And being 30 years in practice, I have seen such a tremendous progress in the treatment of the cancer. So I tell my patients that you have to give yourself some time to digest the information, that you have to be in charge. And there is a lot of support available. Do not feel fearful asking for support. So seek the support from family, support from friends, various support groups. So that's the faith is very important. So it's not only breast cancer. When any newly diagnosed cancer patient comes to an oncologist, I emphasize on a team approach. And I tell my patients that the most important members of the team are patient and the family, because they have to be very comfortable. They have to trust their oncologist. It's such a long relationship. They become almost part of family. So it's always very important to achieve that trust from the beginning onwards. So always have, when the patients they come, I always tell them that you have to bring someone with you, because there should always be two sets of ears, because patients are so overwhelmed that they may not fully understand it. They are fearful. They may listen, but they may not comprehend. They may have a lot of questions. Patients are afraid to ask questions. So there should always be the second person with them. Then another recommendation I give them is always start making a folder and be very proactive. So what I mean by start making a folder is that they should keep all the notes. They should keep all diagnostic studies in chronological order. They should know when the mammogram was done, what was the result, what was the biopsy result, like when Dr. Essa said that what kind of a cancer it was, because breast cancer is a very heterogeneous disease. So they have to take lots of notes. And once they take notes, I tell them that you go home and you read about it, and then you also go online, because the different sources of information helps them to build the trust. They may hear the same thing from me, okay, this is the stage 1 disease and this is the treatment. But at the same time, if they go on internet and learn by various cancer societies, they become educated. So patient has to make an educated decision. They are part of this decision process. So the first thing we have to do is empower the patient. Then what happens that the patients, even if they are very well educated, it comes a shock to them. So I say you have to learn the lingo, that you have to learn vocabulary terms of the breast cancer. Okay, tumor, mass, the size, as Dr. Essa said, that is starting from 1 centimeter to 5 centimeter or more than 5 centimeter, because the treatment differs, the staging differs. So it's very important to be familiar with these terms. Then to have the nodes, the lymph nodes are positive, negative, how many lymph nodes are positive. They all have to understand this. They all have to take the notes. Then another important prognostic marker is estrogen receptor, progesterone receptor. And why they are important? Because we have the dedicated treatment. We have the targeted therapy for that. So it's extremely important for us to know the estrogen receptor, progesterone receptors. Then there are breast cancer, which are called triple negative. And what do we mean by triple negative? That they are negative for estrogen receptor, they are negative for progesterone receptor, they are negative for HER2, and the triple negative breast cancers are considered as a more aggressive kind of a tumor. The next thing I tell them that you have to get familiar with what chemotherapy is. Just in general, chemotherapy can be oral, can be intravenous for the breast cancer. What do we mean by when the oncologist tells you that it's a neoadjuvant chemotherapy? Neoadjuvant is when the tumor is too big. Sometimes we give them chemotherapy before sending them for surgery, so surgery can be done. And we have seen that sometimes the response is so good that when the surgeon goes in, they don't find any breast cancer at all. So that's the role of neoadjuvant chemotherapy. Then what adjuvant chemotherapy means is that the breast cancer, the local treatment has been done, but then they need few months of treatment. So if there are any circulating cells in the system, then they can be taken care of. Breast cancer is a systemic disease. So there are studies done that if stage 1 breast cancer, if either bone marrow is done or the DNA is analyzed in the peripheral blood, 20% of those patients may have the circulating cells. That's why we give them chemotherapy to catch those cancer cells so they don't metastasize. Then the hormonal treatment or targeted therapy. So all these things are very important that the patient gets familiar with these words. The next important step, I tell my patients that remember, as Dr. Asa said, that the breast cancer is not a single disease. If your friend or your family member had the breast cancer of this kind, you may not fall into those categories because no two patients are alike. And every breast cancer patient is unique. Sometimes what happens, the history of the breast cancer changes in the same patient. If somebody had a breast cancer and after 20 years, we have patients where the breast cancer sometimes comes back after 27 years. And then we have to go and biopsy. And at that time, you can see that the patient who was positive for estrogen receptor may turn out to be estrogen receptor negative. Or if the patient was positive for HER2-neu, they may turn out to be HER2-neu negative patients. So it's very important to repeat the biopsy. That's why, because it's such a heterogeneous disease, that there is not a single cure for the cancer. It is always the treatment has to be individualized. So one size does not fit all. I won't go in details. Dr. Asa already said about the ductal carcinoma in situ. But only thing I want to say is that the patients, they get very afraid if there is an abnormal mammogram. So I tell them, don't panic. It may be only inside the milk ducts, and that's the ductal carcinoma in situ. And ductal carcinoma in situ is a stage 0 or a pre-malignant condition. So in common layman's terms, it's not a real breast cancer, but we still have to treat it after biopsy. And the reason we need to treat is because we want to get rid of cancer cells by doing a lumpectomy or radiation. Now, lumpectomy plus radiation. What we mean by lumpectomy means we are removing the part of the breast which has a lump or a mass or calcification. And so what happens with the rest of the breast? Because there may be cells microscopically to the other parts of the breast, so we have to give the radiation. By doing lumpectomy and radiation, we are decreasing the chances of cancer coming back. Few people, they may prefer mastectomy, and there are certain, sometimes there are diffuse calcifications, sometimes the margin of the lumpectomy is not clear, it's involved with the tumor. So in those cases, we recommend mastectomy. And a lot of times, most of the times, we recommend the hormone treatment. Hormone treatment means tamoxifen or aromatase inhibitor, as Dr. Pillai had mentioned it, to decrease the risk of it becoming a real cancer. Then if someone has a DCIS in one breast, there is a higher risk of developing breast cancer in the other breast. So it's important to decrease the risk in the opposite breast, and the hormone treatment helps with that. Now, the breast cancer treatment is the local treatment and the systemic treatment. The local treatment is either what we call is the breast conserving surgery. Breast conserving surgery means the lumpectomy, and mastectomy means when it's the removal of the whole breast. And when I see a lot of patients on consultation, they are very confused whether they should choose lumpectomy or they should choose mastectomy and what the results are. So there are certain medical conditions where we say that you may not be a candidate for lumpectomy. Mastectomy is used when the tumor is too big, or there is a diffuse calcification, or there are some high risk factors. Sometimes, with the mutations, we recommend bilateral mastectomy. So the lumpectomy is always needs the radiation, because we have to treat the rest of the breast tissue also. Mastectomy, we treat with the radiation if the tumor was too big and if there were high number of lymph nodes involvement. Even with the lumpectomy, we have to know whether the lymph nodes were involved or not. But ultimately, we say it's a patient's choice. And why we say it's a patient's choice is that if you see these graphs, the patients who have mastectomy versus lumpectomy, and the big trials have been done, and overall there is no difference between overall survival, disease-free survival, distant metastasis. So it's usually patient's choice, but if patient has an underlying conditions that where radiation is not possible, then we recommend the mastectomy. The systemic management of the breast cancer depends upon the stage, and the stage depends upon the size of the tumor, as we heard before, and the lymph node involvement, even the sentinel lymph node involvement, what the pathology was, what the receptors were, whether estrogen receptors were positive or negative, age of the patient, the menopausal status. And then we individualize the patient preference, then we individualize the treatment and recommend that this is the best recommendation. Whenever we treat any breast cancer patient or any other cancer patient, I tell my patients that the cancer is not a simple disease like a blood pressure or diabetes or something. The standard of care has to be uniform. So all oncologists, they follow what we call NCCN guidelines. NCCN guidelines, whether you go to Memorial Sloan or you get treated by a private physician like me, or you go to any breast cancer center, everyone has to follow NCCN guidelines. They give us some flexibility to make sure that based on patients' comorbid conditions, but overall, we always try to follow NCCN guidelines. So the chemotherapy comes in the form of intravenous medications or in the form of pills. If the tumor is big, then we recommend neoadjuvant chemotherapy. After surgery is adjuvant chemotherapy. The hormonal therapy, most of the time, it comes in the form of pills like tamoxifen or aromatase inhibitors, which blocks the female hormones. Then there is targeted therapy. If patients are HER2 positive, then they get Herceptin and Perjeta and things like that. And those are the targeted therapies. So the early breast cancer, I wanted to touch about the oncotype, which Dr. Essa mentioned before. The oncotype is the recently for last 2 years, even 2 years ago, American Society of Clinical Oncology had a landmark study, and then all media picked it up that there are women who don't need chemotherapy with the breast cancer. And by oncotype, diagnosis, it's mainly done in early stage. We can say that okay, if the recurrence score is low, it calculates the recurrence score by analyzing 70 signature genes. If the recurrence score is low, then those patients in early stage, they don't need chemotherapy. If recurrence score is high, then they need the chemotherapy. Then stage 2, stage 3, they definitely need the chemotherapy. Stage 4 patients, I have patients, with the brain metastasis who had CyberKnife, the liver metastasis, they are getting targeted therapy, living 7 years, commuting every day, going to New York. So no two patients are alike, but stage 4 disease, the advances have converted into chronic disease, like people, they live with diabetes, they live on dialysis, they live with hypertension. So I tell my patients that just as long as the quality of life is good, as long as you're tolerating the treatment, we just will maintain. It's the maintenance chemotherapy. There are a lot of pills available for stage 4 disease, which inhibit something called CDK4/6, like you hear on TV, Ibrance, Pasquale, and all those things have made to live with the stage 4 disease relatively easy. Patients, they take the pills and they go on to their work. For HER2 targeted, there are a lot of targeted treatment available for triple negative, and if they have BRCA2 mutation, there are PARP inhibitors, oral pills available. So we really have come long way in the treatment. The side effects, and there is a long list of chemotherapy. So if the time comes, then we provide them the literature. Then there are short-term side effects and the long-term side effects. Everyone knows about, hair loss, nausea, vomiting. But my first recommendation is that it's worth sacrificing few months of those side effects in a long run. So, that's how we develop our relationship with the patients. The hormonal agents, they can cause blood clots, they can increase the blood clots, they can increase the risk of bone fractures. In long term, there are patients who get damaged by the chemotherapy, their heart especially, and they go on heart transplant list. The bone marrow can get damaged, like ABC Morning host Robbins, she had to have a bone marrow transplant after breast cancer treatment, but extremely rare. That's extremely rare. So these are the two slides I wanted to show you that how complex the breast cancer disease is. Just look at the different kinds of mutations. So it's our learning never stops, and we enjoy, that's why. And we have seen so many advances and so many success stories that we say that it's really an honor to take care of the oncology patient. It's not as depressing as people they feel. Look at the different genetic mutations can happen and the targeted therapy being developed. Based on the genetic mutations, you can have HER2, you can have P13K mutation. So there are different kind of mutations and different kind of treatments available. So take home message, that the patient should never feel with the diagnosis of breast cancer going chemotherapy that they are alone. I tell them you are never alone and you never give up, whether it's a stage 4 disease. And always be positive, always proactive. You are your own self-advocate and you always participate in the decision process. And with that, I will end my presentation, and really thanks for your time and attention. Thank you.
Thank you so much, Dr. Indu Sabnani, for that wonderful presentation. Very thorough presentation there for us. Our next speaker, our final speaker, is Dr. Julie Caballero, a GI specialist who is currently the president of medical staff at Newark, Beth Israel. And may I add, the first woman physician president in over 100 years of the Israel Hospital. Dr. Caballero is a great friend and a colleague. I've known Dr. Caballero and her family for about 30 years now, when her husband was a resident in internal medicine in 1990 at Newark Beth Israel when I was a fellow in infectious diseases. Dr. Caballero did her residency in internal medicine and GI fellowship at UMDNJ. Dr. Caballero has 3 sons, one pursuing medicine, one pursuing dentistry, and one in law school. She has all her fields covered. Her hobbies are traveling and hiking. Dr. Caballero will talk about breast cancer treatment centers and highlight the services of Newark Beth Israel Medical Center as president of the medical staff, as well as briefly touch on risks of GI cancer and breast cancer patients. Please help me welcome Dr. Caballero. Julie?
Yeah, can you hear me?
Yes, I can hear you, but I cannot see you.
Oh, really? My camera's on. Hold on. Let me find out why.
Oh, yes.
Can you see me?
Yes.
Okay. All right. Good. Good evening, everybody. I'm very humbled by being asked to be part of this great activity. I think we're very honored by having such awesome physicians that are joining this activity. We're very humbled by all the audience who took the time to listen to us. I've learned a lot. I'm a physician, but I'm a gastroenterologist, so a lot of this is very important, and I think it's great knowledge for all of us to become familiar with. I'm not seeing the slides. I'm not sure if that, I know that someone was going to be showing the slides for me. Okay, there we go. Okay, excellent. So can everybody see that? You guys can see it full? Okay. So Newark Beth Israel, you know, it's a great place to be in. We have excellent care. We have a heart transplant, lung transplant center. We have an excellent oncology department. Breast cancer being such an important disease, unfortunately, affecting women more commonly than men, but as it's been said multiple times, affecting both. It's actually a disease that it makes a great difference if you can catch it early, but a lot of it has to do with awareness. And Beth Israel is in a community that's mostly a lower income area, neighborhood, as most big hospitals are located in. And we felt years ago it was very important to create a center that would welcome our patients, and they would feel like they were cared for, that we really appreciate them and want to do the best for them. So 3 years ago, the Healthcare Foundation of New Jersey Breast Center was opened at Newark Beth Israel. It's a great place to be in. It's where, as the slide says, it's where class technology meets world-class care. And I think that speaks truth of Beth Israel, because if you've ever been to Beth Israel from the outside, it doesn't look very attractive. It's a brick building. You walk in and you kind of feel like, where am I? But the care inside from all the specialties, it's really superb. So that's why I'm very proud to be talking about it. So like most breast centers, you should look wherever you have your mammography and your studies, that they should be ACR approved. That's for the American College of Radiology. And you can see the gold little circles that they should be displaying at the centers, because you want to make sure that the imaging, obviously, and everything is of the first class. Dr. Partika is our board certified radiologist that specializes in breast imaging at Newark Beth Israel. He's an excellent physician and very caring too. Next slide. Okay. So the breast center, when it was open and throughout the years, has main goals. As I mentioned, we want to provide excellent care to our community. Basically, the major goals have been advancing community health care. As it was mentioned by many of these very bright physicians, early detection of the cancer in the case of breast cancer is achieved through screening. Early detection will lead to prolonged survival. Like it was mentioned, therapy which is less toxic and milder to the patient, easier to tolerate. And also, obviously, if those two things are accomplished, then there will be less related complications with the patient. Providing highly accurate subspecialty care. We do that through our fellowship trained mammographers. I think ours are the best, but obviously I'm biased, you know. But there really are very good people, and by having people who are very trained and very knowledgeable and experienced, because you can be very well trained, but you know, years of practice is actually what's going to perfect your training and your expertise. So improved cancer detection rate through experience is one of the services that we offer. We obviously have state-of-the-art technology, which will be showed in the future slides. Next. So currently, our center is equipped with 3 digital mammography units. We also have 2 tomosynthesis, which are 3D mammography capable units, and these are able to improve cancer detection significantly. And from what I've been told, also in some cases, they're better than regular mammography, and sometimes you don't need to do the ultrasound just because these are superb technology. We also have 2 GE high resolution ultrasound machines, and of course we also have our MRI that we use for detection as well as guided biopsy. Next slide. Beth Israel has been making a large impact in Newark and definitely in New Jersey, where not everybody that comes to Beth Israel is just from local patients. We do approximately 8,000 mammograms a year. All screening mammograms are done with a 3D tomosynthesis imaging. The cancer detection has significantly improved, like most of the doctors already previously mentioned, by using this technology. Part of the problem with especially in many of the poor neighborhoods, poor countries, is the underscreened population, later diagnosis, and therefore less favorable prognosis in many cases. So early detection is definitely our goal, as I mentioned. We have fellowship trained mammographers, as we mentioned before, and the tomosynthesis equipment. We do approximately an average of 500 image guided biopsies a year, and that's using all the different technologies we are equipped to use, the MRI, the ultrasound, as well as stereotactic technology. And we actually have, the good news is out of all those 8,000 mammograms, approximately 120 cancers are diagnosed and treated. So thank God most of them are negative, and that's always good news to receive. Next slide. So tomosynthesis screening and 3D mammography screenings is something that we use, as I mentioned, in all of our patients. It increases the detection rate for approximately 15 to 30%. Part of the slide is missing there. Okay, there we go. It decreases the amount of false positive mammograms, and therefore we also decrease the rate of false recalls. Approximately 50% lower. The false rate has decreased significantly, approximately 15% since the universal use of tomo screening. And I think also by knowing the patient, knowing that we have and we're not the only one. Obviously, there's a lot of hospitals who offer this, but basically this information is being provided. So when you go and get your mammogram, usually your physician refers you, but you also want to check and make sure that all these things are available, and it will make you higher risk of colon cancer. And for the most part, screening colonoscopies, well, it used to be 50 years. Now we've moved down to 45 years old. Patients who are 45 years older with no risk factors, including family history or other diseases that promote that have a higher incidence of colon cancer. But usually people are screened at age 50. However, with patients who have breast cancer, frequently their disease is diagnosed at a younger age, and soon thereafter they should really be referred to a gastroenterology for colonoscopy screening, because there is a higher incidence of associated with both diseases, as it was mentioned also earlier on by one of the physicians. And most colon cancers initiate with polyps, which is just like a little growth, a little pimple growing in the colon that eventually may have the potential of turning into cancer. And when we detect that early on, we are able to prevent many cases of developing into colon cancer. Next. Now, Dr. Subnani emphasized the significance of you feeling that you're not alone. Your family is going to be a big part of making you feel better. It's a very difficult time, the diagnosis of finding out you have breast cancer. At Beth Israel, we pride ourselves. We have navigators that actually, from the moment that you go and have your mammography done, if you're diagnosed with breast cancer, Jacqueline or one of the other navigators will be assigned to you, and they are great facilitators as far as getting everything else from that point on done. I've heard from many patients how grateful they are, whether it's making the phone calls and making other arrangements, following up results of the pathology, talking to the surgeons, later on when you have medications, all that. It's just somebody else who's done this for many other people, and it's an easy, she's always at the end of the telephone call and able to answer your questions. So it's really a very reassuring service. If any of you are interested in contacting the breast center, we also, for many patients who may not have health insurance or be able to pay out of pocket for the cost, we do have a big charity program that you can be incorporated into and properly screened and subsequently treated if that's the case. In order to take advantage of these programs, you can always contact the Breast Cancer Center at the number that's provided on the screen, and you will be guided as to what the next steps are. Next slide. That pretty much completes my presentation. I have the easiest job. So thank you again for listening, and have a nice evening.
Thank you so much, Dr. Caballero, for the Center for Breast Cancer at Newark Beth Israel, and also the risk factor associated with breast cancer and colon cancer. A very important talk in addressing that. So now we're going to go into segment 2. Since we're running late and running out of time, we're going to limit the number of questions if we can. We have a few questions that have come through already, and I'm going to address those. I'll try and give one question to each of the physicians so we can get this thing done. And please keep your answers short so we can try and finish on time. So the first question I'm going to give to is Dr. Pillay. Dr. Pillay, your question is such.
What is the question?
Yes, for Dr. Pillay, what is the role of oral contraceptives and hormonal replacement therapy in breast cancer? I know you've touched upon it quite nicely already. Is there anything you want to add to this question?
Not actually. The hormone replacement therapy data came from the Women's Health Initiative, and we realized that if you combine both estrogen and progesterone as hormone replacement therapy, and if the woman takes it beyond 3 years, there is a higher risk of postmenopausal ER/PR positive breast cancer.
That answer. Next question is going to Dr. Sarah Esau. At what age do you stop mammogram?
That's a wonderful question. There is no real guideline for that, but the way we recommend mammograms is until the age where you have at least a 10-year life expectancy. So the goal of diagnosing mammograms will be to prevent breast cancer or treat them in early stage. So if somebody is 75 and they are with their comorbidities, they have a life expectancy of at least 10 or more years, definitely they should continue the mammogram. But someone who is the same age, bedbound, and with other comorbidities, and doing a screening mammogram does not improve their lifespan in any way, then you could stop it. So there is no age limit. As long as you're healthy and have an expected lifespan of more than 10 years, you can continue to do the mammograms.
Thank you for that answer, Dr. Isa. Next question goes to Dr. Sabnani. You touched upon this, Dr. Sabnani, on the Oncotype. Can you just explain how Oncotype score helps in the management of breast cancer?
So Oncotype is recommended for patients who have estrogen receptor positive tumor, stage 1 or very early stage 2. Very early stage 2 means that they have one node positive and they have a micrometastasis. So what we do is that we submit the papers, and it's done on the pathology specimen, and they give the recurrence score. So if the recurrence score is less than 7, less than 9, they say then the 5-year risk of recurrence is, say, almost 0% or 1% or 2%. So those are the patients that they will not need chemotherapy. They will only be treated with the hormonal agents like tamoxifen or aromatase inhibitor. In addition, the tumor has to be HER2 negative. Then if the recurrence score is intermediate, then we look into the other factors, whether there are any other factors, whether the breast cancer was poorly differentiated, whether the Ki-67 was high. In those cases, then we make a decision in participation with the patient. And the high score patient, even patient is young or whether it's a stage 1 disease, the high recurrence score, they definitely go on chemotherapy.
Thank you, Dr. Sabnani. Now, the last question is for Dr. Caballero. At what age is colonoscopy recommended if you have no risk factors? And how often should you get your first colonoscopy? At what age is colonoscopy recommended if you have no risk factors? But by how often should you get a colonoscopy? Julie? Can we see Julie? Is she signed off?
She's on mute.
Oh, she's mute.
So
Really?
let me answer a little briefly. I think Julie knows it better, but the colonoscopy used to be, the recommendations was at the age of 50 years, the initial colonoscopy. Julie can correct me, but we are seeing a lot of young patients having the colon cancer. Like, the guy from the Black Panther, he died at such a young age with the colon cancer. The colon cancer is much higher in African-American population at a younger age. So recently, I think this week or something, there was a lot of talk in media that the screening guidelines have been changed, and at age of 45. This is without the risk factors. And how often you should get, usually they say every 10 years, but if there are polyps or if there is anything else, then the recommendations are every 5 years. If there are polyps, then sometimes Julie says get it every 3-4 years to make sure there was no other polyp growth. Don't quote me, but I think these are probably the consensus.
Okay. Thank you so much for answering that question on behalf of Dr. Caballero. Next, I'm not sure if Sudhir or somebody could give me an indication. Should we go forward with more questions, or should we start the wrap-up process? It's getting close. It's 10 o'clock, actually. Just give me a word on that.
I think you can ask the audience if they have any questions. So,
okay. Are there any questions from the audience?
So what would be a good diet that would prevent
there's a question
from happening? So something like a holistic diet or holistic eating plan that would actually prevent breast cancer from happening.
Maybe Dr. Pillai can answer that question.
Okay, this itself is a topic for a 1-hour lecture, but let me just keep the 2 sentences. The best study is about the Mediterranean diet, which is basically a plant-based diet. and it has fish in it, olive oil. The Mediterranean diet was tested for preventing cardiovascular disease, but in retrospective analysis, they found that the patients on Mediterranean diet had a lesser incidence of breast cancer. So it's a retrospective population-based study. The second study I can quote is the American Association of Retired Persons. They did a study of looking into the content of fat in the diet. If your daily diet contains more than 40% of the calories from the fat, then you have a higher incidence of invasive breast cancer in that population. The problem with diet studies, there are other confounding variables. Many of these patients are obese. Many of these patients do take alcohol. They do not exercise. Some of them are nulliparous and prolonged and delayed menopause. So that's why the area is still controversial. But a good take-home message would be a plant-based olive oil, fish-rich diet has been found to be associated with lesser incidence of breast cancer.
Okay. Thank you,
Thank
Dr.
you.
Are there any other questions from the audience?
Dr. Elizabeth, sorry. This is Shiva Roy from Houston. I have a question, and I really applaud WMC for arranging such a great event with wonderful panel of speakers. So my question is, we have learned that men get breast cancer too. So my specific question would be, like, what precautions should men take, or how do they know that they are at risk of breast cancer?
I give that question to Dr. Sarah.
Yes, men can get breast cancer even though the incidence is rare. The precautions are usually for people who are from a cancer, from a family that has a high risk of cancer. For example, in a family there are women with BRCA2 positive gene. Men in that family should be screened for the BRCA gene. Again, BRCA2 gene is also associated with pancreatic and prostate cancers. So, so family history of breast cancer, especially genetic mutation, those families, men should be more aware of, or maybe screening for breast cancer. Other than that, there are no real specific screening tests for men or screening mammograms, but they have to be aware of their anatomy. If they notice any unusual or asymmetry in their breast, one breast is larger than the other, or if there's any palpable lump, they should be seeking medical help as soon as possible, rather than thinking that it's something like a cyst that'll go away. But any unusual swelling or lump in the breast should raise concern in men also to get a biopsy and get checked out. But there's no screening guidelines for men.
There's one question that just came in for men, is anabolic steroids in men and the risk of breast cancer in using that. Dr. Sarah?
I'm not aware of any.
Bodybuilding guys who take anabolic steroids put them at higher risk of breast cancer. I thought it was more testicular cancer, but if you
it's not linked to breast cancer as far as I know.
Thank you. The questions from the audience? Go ahead.
This is Sansi Talachalur from the North Texas province. My question is there any studies or research regarding the daily use of perfume and deodorant have a risk of the breast cancer?
I pose that question to Dr. Sabnani.
So it's again a very controversial topic. Aluminum base say that there is some risk, but the studies have not clearly proven. But I see that lot of health conscious patients and the friends that they have been moving away from aluminum based deodorants. Perfume is exactly not, I'm not aware of any studies. Maybe my knowledge is limited. It's not like the talc powder associated with the ovarian cancer. That is more documented.
Thank you. Any other questions from the audience?
Yeah, I have a question. My name is Leela Merritt. Congratulations to WMC and the wonderful panelists. My question is, recently we are hearing about immunotherapy for the cancer cure. Can you explain what is immunotherapy, the latest cure?
Yeah, Elizabeth, I'll take this question. So immunotherapy is basically there are some kind of the pathways in the cells which programs the cell to die. So somehow that these are called check inhibitors. They keep everything under control. So there are these drugs available which can be used. The immunotherapy is most commonly used for the kidney cancer, for the head and neck cancer, for the colon cancer, for the lung cancer. In lung cancer, it has really revolutionized the treatment for the lung cancer. But for the breast cancer, also the immunotherapy is being used. It does not kill the cancer cell directly, but it kind of changes the body's immune system. It makes the immune system stronger. And by making the immune system stronger, it kills the cancer cells. There are a lot of side effects. When the immune system becomes overactive, they develop a lot of skin rash, diarrhea, the thyroid problems. For breast cancer, it's still under phase 3 trials, and it's mainly for the triple negative breast cancer that the results have been coming out positive.
Thank you.
Anybody, audience? Okay. There's one question that's coming through. What impact does stress have on comorbidity or any comorbidity have on breast cancer? I guess basically stress affecting breast cancer, causing breast cancer, I should say.
I can just answer a little bit in a short form, is that it's everything these days has to do with the inflammation in the body. Stress increases the inflammation in the body. The foods which are high in glycemic index, the fat-rich foods, they increase the inflammation in the body. So basically, because of the stress, the body's inflammation is very high, and the people, they say the fighting ability goes down, and stress always plays a role, whether it's the heart disease or any other kind of a disease. And the comorbid conditions, of course, if a patient has a heart failure or has a heart situation, then we cannot use Herceptin, we cannot use adriamycin chemotherapy. If patient has other comorbid issues, the poor lungs or other things, obesity is definitely a risk factor even for the treatment. Exercise improves the survival in breast cancer patients, even when they were treated. So we strongly recommend that they should maintain ideal body weight and continue to do the exercise and stay active.
Thank you. I think one last question, unless there's more. Somebody asked, the breast cancer is called Nunn's disease. Can you explain?
Yeah, that's what Dr. Pillai has explained before, because there is longer exposure to the estrogen because of nulliparity, not having any pregnancies, that will increase the risk of breast cancer in nuns. So that would be the reason for breast cancer being known as that.
I have a question. Dr. Pillai said men with the XXY, they have more chances to get breast cancer. How do we identify people or men with the XXY?
Dr. Pillai, you're muted. We cannot hear you, Dr. Pillai.
Can you hear me now?
Okay, now we can hear you, yeah.
Okay. If you go to any genetic counseling department, they can refer you to a good cytogenetics lab, and they can identify the XXY phenotype by a simple blood test. But I wouldn't encourage you to just go and get it done for curiosity's sake. All these tests are supplementary to a clinical diagnosis. Otherwise, you're wasting your money and you're raising your anxiety level. So if you have a doubt about gynecomastia and a tendency of developing breast cancer in a male patient, and other features of Klinefelter syndrome will be detected by your physician, then it is worthwhile checking it.
Thank you.
Anybody else? Audience? If not, we will start the wrap-up portion of this. Sudhir, is there any other questions that's coming up?
I don't see any questions coming up.
Okay, so then
Is
I'm
there
going to start wrapping
anyone?
up. Okay, so first of all, I want to thank, okay, sorry. Let me get to the wrap-up section. To conclude and to wrap up, before I sign off my portion to Mrs. Annie Monticelli, I want to thank the panelists, Dr. M.C. Pillay, Dr. Sarah Issa, Dr. Indu Sabnani, and Dr. Caballero for the valuable time and their presentation in this WMC Virtual Breast Cancer Awareness Program. They gave us insight on the importance of screening for early detection and best survival rates, risk factors, diagnostics, treatment, and what to look for in treatment centers. I want to thank the audience for their questions, participation during this interactive session, during the Q&A. I want to specifically thank the President of WMC America Region, Mrs. Sudhir Nambiar, AR General Secretary Pinto Kanapalli, Women's Forum President, Mrs. Shoshana Andrews, AR Vice Chair, Mrs. Shanta Pillay, AR Women's Forum Secretary, Mrs. Alice Monticelli, for their leadership in making this program possible. Also appreciate the efforts of the global team as well. And I don't have the time to mention all of them. But once again, thank you to WMC for this wonderful program and having us on board. Now I turn the program over to Mrs. Alice Monticelli, Women's Forum Secretary. Thank you.